So coming to my talk, I have been asked to talk on managing severe preeclampsia and hypertensive crisis. And we all know that hypertensive disorders of pregnancy, along with postpartum hemorrhage, and is the most important, reason for maternal morbidity and mortality globally. And severe preeclampsia is a potentially life-threatening multi-system disease that requires urgent management in a high dependency setting. So I'll just start with a case. I hope you can see my slides. Hello. Hello.
Can see, ma'am, clear.
Okay. So I'll just present the case. This is a real case. A 25-year-old primary gravida referred with 32 weeks pregnancy, well booked, edema for last few days. BP was normal till the problem occurred. Epigastric pain for 2 days, treated with antacids, did not improve, admitted in afternoon. BP 140/90. Again, injection pan top repeated. At 11 p.m., she had convulsions. She was catheterized. There was frank hematuria. You can see the catheter having frank, bag having frank hematuria. Platelet count 46,000. Injection max self given. And then she was transferred at 1 a.m. to a tertiary care hospital. The condition was unsatisfactory. Patient was confused, not pale, edema plus, pulse very high, BP very high, 150/110. Uterus was 28 weeks, relaxed. Fetal heart was very, 158. And the catheter shows tube empty. This patient was, delivered and given renal replacement therapy, but we could not save this patient. And this is a very common scenario which we have been seeing in the hospital. So what you see, 2-3 important points in this. BP was normal till the problem occurred. Epigastric pain for 2 days. So what was the reason for the BP normal? Was the BP taken normally? The important thing that we have to take care of is that we should be, care should be taken during BP measurement. And especially as Dr. Piley has also been, talking about the training of the peripheral workers. It is very, very important that they take the BP in a proper position, in a sitting position with empty bladder, no tight clothing, appropriate cuff size. Patient should be silent. She should not have any caffeine or smoking. The corticof sounds first for systolic, 5 for diastolic blood pressure. Supine position, important is supine position can lead to underestimation of blood pressure. So if the patient blood pressure is measured in the higher arm in the left lateral position, it may also get false low values. So it is important that how the BP is being monitored, and then everybody should know how to take a BP properly in the sitting up position as well as in the lying down left lateral position. The second important thing here was that she was having epigastric pain. So what she should have been for 2 days. Should she have been referred earlier? So what is the definition of preeclampsia? Now the definition of preeclampsia has changed, that it is, of course, the systolic blood pressure is more than 140 diastolic more than 90 after 20 weeks of pregnancy on two occasions, 4 hours apart, but with or without proteinuria. So important is that previously we always used to say that preeclampsia with is there, proteinuria is a must. But now we are saying that preeclampsia can be there with or without proteinuria if it is associated with severe features. What is the severe features? The severe features are systolic blood pressure more than 160, diastolic more than 110, thrombocytopenia is important, platelet count less than 1 lakh, impaired liver enzymes, or which can be twice the normal concentration of the liver enzymes. It is significant. Severe epigastric pain, right upper quadrant pain, because of which is not responsive to medication. See, in this case, which I have talked earlier, the patient was not, which was given antacids. she was again given Pentop, so she was not responding. So that we have to think of, case of the severe preeclampsia with severe features. And again, here I would like to highlight that now the definition is changed. We don't use the word severe preeclampsia, rather it is said that preeclampsia with severe features. So again, besides the high blood pressure, thrombocytopenia, impaired liver enzymes, and the epigastric pain, if there is a decreased urine output or serum creatinine ratio is more than 1.1 milligram per deciliter, or evidence of pulmonary edema, or there are new onset of cerebral or visual symptoms such as photopia, scotomata, cortical blindness, etc., all this will be labeled as preeclampsia with severe features. And in this case, again, the hypertension is again classified into two, non-severe and severe. Non-severe is 140 by 90 to 159 by 109, or severe more than 160 by 110 or above. So how will be, my talk is to be focusing on management of preeclampsia with severe features. So what should be the management protocol? Identification of high risk patients, optimization of the antenatal care, early intervention to prevent complications, identification and early management of complications. And how it will be done? By patient monitoring, by treatment of hypertension, fetal surveillance, deciding the timing of delivery. And we have to understand that severe preeclampsia is a medical emergency, and patients should be managed in a critical care unit to facilitate close monitoring of vital signs, as well as the titration of the treatment and early recognition and management of complications. Coming to monitoring, I will be very short about these things, because most of the things have been talked earlier by Dr. Prakash Mehta, how to monitor patients in the ICU or HDU. So coming to the monitoring, we of course have to monitor the blood pressure regularly, every 15 minutes in severe cases, watch for signs and symptoms of impending eclampsia, and of course get the tests like platelet counts, liver enzymes, renal function test, and lactic acid assessment, and of course peripheral smear for hemolysis, LDH assessment also. Next, if we look at the treatment point, how should you treat the next point was treatment of hypertension. So when should you treat the hypertension? Should you treat the hypertension after 150, or when the systolic blood pressure is more than 150 and diastolic more than 100? Or should you treat it after more than 140 by 90? The latest NICE guidelines say that you should start antihypertensive medications when the systolic blood pressure and diastolic blood pressure are more than 140 by 90. And we also follow the same thing. But it is important that treatment is mandatory for severe hypertension when the blood pressure is more than 160 by 110 millimeter of mercury. So what are the benefits of antihypertensives? The antihypertensives reduces the incidence of complications. Treating severe hypertension prevents maternal cerebrovascular accidents and placental abruption, leading to decrease in the maternal mortality and fetal mortality. Reduce mortality due to hypertensive induced complications. But here we have to understand that giving antihypertensives does not halt the disease progress. The disease progress is there, but only thing is the only cure is delivery. But only thing is you can control it, and you can do the delivery for for reducing the mortality. Should you treat mild hypertension in pregnancy? Is it not? It's not very, very clear, because it is said that it does cause reduction in severe hypertension development, but how does it improve the perinatal outcome? That is not very, very clear. So, but as far as the new guidelines are concerned, NICE guidelines are concerned, we have started treating the patients when their blood pressure is more than 140 by 90. The aim of antihypertensive therapy is to bring the target to BP to 135 by 85 millimeters. So now the target has also reduced 135 by 85. But it is important that we should not, be reducing the blood pressure, within in an overzealous manner, because it can cause, hypotension. Sudden hypotension can cause placental hypoperfusion and compromise fetus. So it should be done slowly. And what are the drugs which are available? As Dr. Piley has said, that we have a long experience with methyl dopa. It is one of the very good drugs, but at the moment we are not, able to get it in the market. The other drugs are labetalol, nifedipine, hydralazine. I'll be talking about them in detail. Labetalol is the drug of choice in the nowadays. Initial dose 100 milligram BD, which can be increased at weekly intervals by 100 milligram twice daily in the mild cases where there is hypertension is not very severe. Titrate the dose to 100 to 400 milligram TTS, and maximum dose can be as high as 1200 milligram per day. It has been seen that there is a large gap between the toxic dose and maximum dose. So sometimes some people do advocate that you can increase the dose to even 1600 or 1800 milligram per day also. Advantages of labetalol are that it leads to decreased peripheral resistance without significantly reducing the cardiac output and heart rate. It maintains the placental perforation and, of course, fetal oxygenation. It ensures better and quick control of blood pressure. It is better tolerated, ensures safe prolongation of pregnancy, and maternal or fetal outcome is better in labetalol group as compared to methyl dopa. But still, our experience with methyl dopa has always been very good. Coming to the severe and acute hypertension, we have got three options. We can use labetalol, we can use hydralazine, we can use nifedipine. Previously, it was it was said that only when you start with one drug, if you are starting with labetalol, continue with labetalol. Do not change it to other drugs. But now we are saying that we can, after, if the response from one drug is not good after 3 doses, then in those cases we can shift over to we can add another drug, and we can, control the blood pressure. So labetalol is the drug, initial drug which we started in our hospitals, 20 milligram IV, which decrease the BP and look at the BP. If it should, lead to fall in blood pressure in 10 minutes. And if BP is still above the threshold, then give 40 milligram IV. Again, check the BP. If there is a fall, it's good. If it is not there, then again you can increase, give this 80 milligram IV, and it look for the fall in BP in 10 minutes. And if no response is there, then in those cases, we change it to, you can add, change to difetapine or hydralazine. And but when we say that BP, if more than threshold is there, then in those cases we can add hydralazine also in those cases. So initially you can start with labetalol, give 20, 40, 80, no response, then or response is not satisfactory. In those cases, shift over to nifedipine or hydralazine. And similarly, if you start with hydralazine, so the choice of the drugs is mostly dependent on the person who has got, on the obstetrician. But all the three options are having a good response. Hydralazine, you start with 5 to 10 milligram IV, which observe BP, repeat in 20 minutes. If then again give 10 milligram IV. If again BP is not falling, or then repeat in 20 minutes. And then, of course, the BP reduction we expect is that about 20 to 25% BP reduction should be there after the doses. Then nifedipine, 10 milligram orally, should lead to decrease in BP in 20 minutes. BP, again give 20 milligram if there is no fall in a decrease in BP in 20 minutes. And of course, if there is no response, then response is poor, in those cases change over to labetalol or hydralazine. Add labetalol or hydralazine. So the drugs which should be avoided, so all the three drugs can be used, and you start with one drug and add another drug if the response is not satisfactory. Drugs to be avoided in pregnancy are ACE inhibitors and ARBs, that is angiotensin 2 receptor blockers, because they can lead to be, even in second trimester also, they can lead to be teratogenicity. And mineralocortical receptor antagonists like spironolactone, antiandrogens, they cross the placenta, so they should not be used. And beta blockers have been seen to be giving rise to FGR, first trimester exposure may increase congenital heart disease, so they should be avoided. Again, besides the antihypertensive treatment, it is very, very important to see the fluid management in preeclampsia. Dr. Prakash Mehta has also talked about the role of importance of fluid management in critically ill patients, but it is important that we have to see that our aim should be to restore and maintain circulatory volume to preserve the kidney functions while limiting the potential for pulmonary edema. So we have to keep a balance that there is renal functions are okay, but it is not leading to overloading and leading to pulmonary edema. So how will you assess the fluid balance? The accurate assessment of fluid balance is important, and it can be done by CVP. Dr. Mehta has already talked about CVP, but initially, traditionally, CVP was being used regularly for assessment of intravascular volume, but nowadays, we are using non-invasive methods. Even pulmonary artery catheter has the benefit of course, telling us about the right heart pressure, but again, it has been seen that it does not reduce the mortality. So nowadays, we are using the dynamic test of fluid responsiveness, that is the inferior vena cava collapsibility. Dr. Mehta has talked about it. If IVC collapses more than 50% during inspiration and its diameter is less than 2 centimeter, then the patient is fluid responsive and there is no fluid overload. But if it is more than 2.5 if the diameter is more than 2.5 centimeter with no collapsibility, or the collapsibility is less than 50%, it suggests that patient has got volume overload. So this is a bedside test. You just put a linear probe on the inferior vena cava, and you can assess the fluid responsiveness, which is very, very important, especially in the cases of severe preeclampsia, who can very easily go into pulmonary edema if not you have not taken care. So how should you manage, fluid management should be done in preeclampsia. All fluids should be, infusion should be done through a volumetric infusion pump. Sodium chloride, which is very close to the plasma, we should be using that as the fluid of choice. And we should avoid solutions with high water concentration like dextrose 5%, etc. And how much should be given? How much fluid should be given? Restricting IV fluids associated with lower rates of pulmonary edema without an increase in acute renal failure is seen. The amount should be less than 80 ml per hour, which is the recommended dose. I have seen patients, dying because of people not knowing how much fluid to be given. Intern was monitoring a patient and he gave 5 bottles in just, 2 hours for the patient, and patient died because she was a case of severe preeclampsia. So it is very, very important that how much fluid to be given, which fluid to be given. And if the patient, you should also keep into mind about the patient's weight. The patient, if it is a thin patient, then she should be given less blood. And of course, the fluid should not be more than 75 ml per hour in the cases of severe preeclampsia. 1 to 1.5 ml per kg per hour can be provided if there is no requirement for other fluids. But if the other fluids like is required, like blood and other products are required, in those cases it has to be reduced. Next thing is that prophylaxis for convulsions. The most important complications which we anticipate in severe preeclampsia is convulsions. So in this, it is important that the evidence clearly confirms the efficacy of magnesium sulfate in reduction of seizures in women with eclampsia and severe preeclampsia. However, this benefit does not affect overall maternal and perinatal mortality and morbidities. So how much to be given, that I will be talking later on. So after this, the third thing which we have been talking, the first thing I talked about the monitoring in the management. The second thing was about the antihypertensives and the fluid management. The third important thing is, of course, the fetal surveillance. Severe preeclampsia is associated with FGR, and FGR, for assessing FGR, it is important to do an ultrasound biometry every 2 to 3 weeks, and fetal Doppler in cases of FGR. And then fourth thing is the timing of delivery, because the ultimate cure for severe preeclampsia or preeclampsia is the delivery. So the mother with preeclampsia should be stabilized, but it is very important to stabilize the mother before, delivery. You plan for the delivery. You don't start, inducing the patient because she's having a severe preeclampsia. First, stabilize the patient, control her blood pressure, see her perfusion, and see her respiratory status, and then only you think of, doing a termination of pregnancy. Termination should be done at 34 weeks in severe preeclampsia. Earlier, if woman is deteriorating or developing complications like HELP syndrome, or corticosteroids should be administered if the maturity is less than 34 weeks. But you should not, it is not important that you should keep on waiting for the corticosteroid effect. If the patient is deteriorating, then termination should be done earlier. Next thing which Dr. Shai just really wanted me to talk is about the hypertensive crisis. So severe preeclampsia, we know the delivery is the cure for, what is the hypertensive crisis? Hypertensive crisis is the word which refers to clinical situations in which the blood pressure is elevated and there is either acute or impending end organ damage. So if a high blood pressure, acute high blood pressure leading to impending and end organ damage, it will be labeled as hypertensive crisis. Acute hypertensive crisis most commonly occurs in severe preeclampsia and is associated with maternal stroke, cardiopulmonary decompensation, fetal decompensation due to decreased uterine perfusion, abruption, and stillbirth. So all these, patients coming to your obstetric critical care units are, so many patients come with maternal stroke and cardiopulmonary decompensation who are having hypertensive crisis, and they should be really, really monitored in a critical care unit. Immediate stabilization of the mother, including the use of intravenous antihypertensives, is required. Often, as discussed earlier also, delivery is the hallmark of treatment. The treatment of hypertensive crisis must balance preventing further complications, further end organ damage, while maintaining the tissue perfusion. So what will be the initial goal? The reduction in blood pressure, which is not to obtain a normal blood pressure. The aim should not be not to obtain normal blood pressure. Rapid and aggressive reduction in blood pressure can actually rather induce cerebral myocardial or renal ischemia or infarction. So if the blood pressure falls below the range at which tissue perfusion can be maintained by autoregulation, then it will lead to more damage. So it should be normal blood pressure should be obtained slowly. Consider at what rate and to what extent the blood pressure should be lowered. All patients with hypertensive crisis should be admitted to an ICU where continuous arterial blood pressure monitoring can take place. Intravenous medication should be used so that predictable and controlled change in blood pressure is recorded. The initial reduction in mean arterial blood pressure should not exceed 20 to 25% below the pre-treatment blood pressure. A more gradual decrease in blood pressure should be sought over within the next 24 hours. Excessive rapid reduction in the blood pressure are dangerous, and as the signs and symptoms of acute end organ damage are controlled, parenteral therapy can be gradually weaned off. And while initiating the oral medication, it is important that initial doses of oral medication should be given before the parenteral therapy is stopped. So how do you manage the severe acute hypertension? First line, as I've already talked about in the management of severe preeclampsia, is the same: IV labetalol or hydralazine. If no IV access is there, immediately you can, immediate release oral nifedipine can be given. And even if you don't have nifedipine also, then at least if you have you cannot give IV, you don't have nifedipine, then in those cases, tablet labetalol orally can be given, repeated after every 30 minutes. But of course, first line of medication is IV labetalol and or hydralazine. So these I have already discussed. The doses are the same. These are the first line of management. But if the it is important to have a multidisciplinary team, emergent consultation with cardiologist or critical care subspecialist to discuss the second line intervention is recommended. And second line alternatives are nicardipine or esmolol by infusion pumps, or sodium nitroprusside should be reserved only for extreme emergencies, because it can lead to cyanide correction poisoning. And of course, anti-G drip is the most important treatment, especially in the cases who have got pulmonary edema. So we can use nicardine, we can use sodium nitroprusside as the last resort, but in the cases of pulmonary edema, we use nitroglycerin, which we routinely use in our hospital. Should be started at 2 to 5 microgram per minute. The mechanism of action is fast, and it can be increased by 5 microgram per minute IV, and so that and blood every 3 to 5 minutes it can be increased, maximum up to 200 microgram per minute, and it can lead to fall in blood pressure, and especially in the acute pulmonary edema cases, because in those cases we cannot give labetalol, which leads to worsening of these cases. Again, the critical complications in hypertensive disorders are, besides the hypertension, which is leading to these complications, is the seizures, acute pulmonary edema, neurological impairment, ARF, and oliguria, anuria, eclampsia, HELP syndrome is seen in about 10 to 25% cases. AKI is seen about 1 to 5% of cases. Pulmonary edema is seen in 2 to 5% of cases, and placental abruption is seen in 1 to 4% of cases. So it is very, very important that we should take care of prevent these complications by really promptly managing the severe preeclampsia and acute hypertensive crisis. So I will be talking about these complications in very short, because these complications, if you talk about these complications, they in per se are very, very, elaborate. You can take full 2 days lecture on these complications. So I'll be just talking about the highlights, high points in these complications. But it is important that can you predict these complications? Before I talk about the complications, can you predict? Dr. Mehta has talked about the scores which we have been using. So in this also, severe preeclampsia, prediction of critical complications in hypertension disorders can be done by Peier's model. Peier's models are 2 types: full Peier's model and mini Peier's model. Mini Peier's models is mainly based on the history and examination, but it is does not take into consideration the lab parameters. And the full Peier models take into consideration about the lab parameters. You have a scoring which you put on the calculator, and you calculate that this patient has got the risk of critical complications in the cases of severe preeclampsia, and so that counseling can be done, and you can assess the risk of morbidity and mortality in those cases. Coming to the management of these important complications, we all know seizure control has to be done by magnesium sulfate. Pritchard regime, I don't think this August gathering knows about, I have to be told about Pritchard regime, but of course we have to give the loading dose and maintenance dose as 4 gram IV, and maintenance dose 5 gram in deep intramuscularly in alternate buttocks. But most of the times it is better to do a response regime, because you can control the drugs by giving IV regimes. The loading dose is again 4 gram IV of magnesium sulfate, and maintenance is 1 to 2 gram per hour. But here I would like you to understand that in renal sufficiency, it is important that we should be giving the dose, much lower dose. Loading dose may be same, which can be given safely in patients with renal insufficiency, but Zuspahn regime is advocated if facility for magnesium level are present. We should follow the Zuspahn regime, especially in renal insufficiency. If the serum creatinine is 1 to 1.5 milligram, then you should, maintenance dose is reduced by half. And if the maintenance dose to be withheld, if the serum creatinine level is more than 1.5. So it is very, very important to see that even, the patients of severe preeclampsia who are more prone, who are having convulsions, and they are more prone for renal insufficiency. So creatinine levels should be done before, you give the maintenance dose. Of course, loading dose has to be the same. If there is a recurrent seizures, we have to give, we can give diazepam, or we can give lorazepam, but initially, of course, we will give Maxsurf 20% 2 gram IV if there is a recurrent seizure. But nowadays we are giving midazolam, which is getting a very good effect, 1 to 2 milligram bolus given IV at a rate of 2 milligram per minute. So midazolam is giving a good, if the patient is having recurrent seizures, not responding to Maxsurf, in those cases, midazolam is giving a good work. Again, very important complications of severe preeclampsia is the acute pulmonary edema, which can be iatrogenic also if you have not given fluids properly. It is a leading cause of death in women with preeclampsia. 3% of women with preeclampsia can develop acute pulmonary edema, and 70% of these cases have been seen even after delivery. And the signs and symptoms we all know: respiratory distress with tachypnea, crepitations, desaturation, and chest X-ray features shows alveolar opacification, which gives like to classical, bat wing appearance. So it has to be very, very, important that you should keep the fluid. The fluid should be given very, very judiciously in the cases of severe preeclampsia. And of course, urgent reduction of critically high blood pressure has to be done by intravenous antihypertensive. Anti-G, as I have recommended earlier also, I have said, as is the drug of choice in preeclampsia associated with pulmonary edema. Get electrocardiography, chest X-ray, blood pressure, and oxygen saturation. Monitor heart rate, pulse rate, heart rate, respiratory rate, and temperature and fluid balance. And of course, positive pressure ventilation is advocated. NIV in selected cases can be given, but very, very, in most of the cases, the patients need invasive mechanical ventilations. And furosemide 20 to 40 milligram over 2 minutes can be given. The dose can be repeated after 30 minutes if no response is there. But we have to again be very, very cautious, because these preeclamptic tolerate fluid depletion also very poorly, and intravenous morphine 2 to 3 milligram may be given as a venodilator and anxiolytics. And of course, fluid restrictions has to be taken into consideration. Neurological complications, most common are the posterior reversible leukoencephalopathic syndrome, and of course a stroke, which can lead to death or disability, which is the most serious complications. And eclampsia is the most common cause of both ischemic as well as hemorrhagic stroke of pregnancy. But should all the patients of severe preeclampsia or eclampsia should get imaging done? The only need for cerebral imaging, it has been seen that it is not necessary for the diagnosis and management of most of the women with eclampsia. Findings in eclampsia is similar to those found in patients with hypertensive encephalopathy. So imaging to be done if there is focal neurological deficit, if there is a prolonged coma, if there is atypical presentation for eclampsia, if the onset is before 20 weeks or onset is more than 48 hours, or eclampsia is refractory to adequate magnesium sulfate therapy. So important thing here to highlight is that eclampsia, we all know that the patient will be having, some findings in cases of eclampsia. But if the findings are abnormal, in those cases only we should, imaging should be done. It should not be advocated for every patient. The PRES, which is the most common, complication which is observed, which is a clinical radiological syndrome of heterogeneous etiologies, which are grouped together. So of findings, because of the similar findings on neuroimaging, it is only diagnosed by doing the imaging. So in those cases, you have seen that it is, the treatment is, clinical presentation is headache, altered consciousness, visual disturbances, seizures, which are usually tonic, clonic, and they begin focally also. And the treatment is of course supportive, ICU, ICU care, immediate delivery, optimized blood pressure, and of course magnesium sulfate and mannitol. It should be given or should not be given. It is very, very limited, and it is always given with a neurological opinion. Rather, it has been seen that giving mannitol can worsen the brain edema in some cases, because it is the severe preeclampsia cases, they have got already the fluid depletion state is there. So in those cases, it is seen that it can be harmful. So we should be very, very careful regarding giving mannitol. I have seen people just ordering mannitol whenever they are thinking that patient has got a PRES. in those cases. So we have to be very, very careful. The other complications in the hypertensive, severe preeclampsia leading to hypertensive crisis in those cases can be HELP syndrome. The combination of, we all know it is combination of hemolysis, elevated liver enzymes, and low platelet count, and it complicates about 20% patients of severe preeclampsia, which is the most common, complications for which the patients are admitted in the obstetric ICU, and approximately 30% cases do occur in postpartum period also. But it is important to identify that if the patient after delivery to 3 to 4 days of delivery is not improving, then it is, you should think of something else, then it is not HELP. So we have to, diagnose HELP, keep the differential diagnosis of HELP in mind, that is the thrombocytopenia, thrombotic TTS, HUS, or the acute fatty liver of pregnancy. HELP tends to be more severe, and its features are hepatic infarction and subcapsular hematoma, which can be very, very dangerous. And of course, in acute fatty liver of pregnancy, there will be, hypoglycemia, there will be aggressive, severe jaundice in those cases, and associated with DIC. So we have to, our management will depend on, the diagnosis also. So you have to keep in mind the HELP, whenever you are thinking of a case of severe preeclampsia, it is very, very important to send all the coagulation parameters, and especially the platelet counts. And in the treatment of HELP is, of course, platelet transfusion should be considered if the platelet counts fall below 20,000 or 50,000 if an anti-interventional procedure is required. The risk of bleeding into the epidural space is significantly reduced with a platelet count of more than 75. So epidural analgesia can be given if the platelet count is more than 75,000. Of course, the treatment for AFLP as well as for HELP is both the most important is the delivery of the fetus, and we have to, as I have said earlier, that 30% cases do occur postpartum. So we have to be careful in the postpartum period also. The last most important complications in which we had in the case which I had presented earlier, or is the acute kidney injury, which is, is the incidence is as high as 1 to 5%. It is common in women with HELP syndrome who has got severe preeclampsia with HELP syndrome. And the case which I had presented earlier, it also had, severe preeclampsia with HELP syndrome and with AKI. Warning criteria is, of course, we have to keep on monitoring the urine output. Any sustained fall in urine output or a rising serum creatinine just will alert you about the AKI, and action should be taken immediately. Management of AKI again is the optimizing the intravascular volume, avoiding nephrotoxic drugs, treating the underlying cause, use of furosemide or dopamine to increase the urine output in the absence of fluid overload does not improve. So it is important that if there is no fluid overload, there is no signs of pulmonary edema or fluid overload, you should not be giving furosemide or dopamine to improve the renal perfusion. Magnesium levels should be monitored closely, and of course renal replacement therapy should be started early if there is a hyperkalemia, if there is metabolic acidosis which is resistant to medical therapy, or uremic pericarditis, or uremic encephalopathy, and fluid overload which is resistant to medical therapy. So early renal replacement therapy can, really save patients if they in the cases of severe preeclampsia or hypertensive crisis. So to finally, I would just like to say that the messages which you can, think and remember: close monitoring of a patient of preeclampsia is very, very important. Antihypertensive prevent complications but do not halt disease process. Termination of pregnancy is the only cure. It cannot halt if you have not done the termination, the process will not be halted. It can be only controlled. Magnesium sulfate for prophylaxis of convulsion should be given. Continue monitoring for 72 hours postpartum, and disease of severe preeclampsia may persist till 4 to 6 weeks after delivery. So one have to be, careful in the postpartum period also, and prompt identification and management of complications can definitely reduce maternal mortality. So one must identify the HELP syndrome, the acute pulmonary edema, the AKI, and of course the convulsion, eclampsia, and acute hypertension. So early, so that prompt treatment can save the patient. Thank you very much.